The next section is intussusception and volvulus. These are also abdominal, you know. So the abdominal surgeries are many. So this is also to do with the intestine. So we go with intussusception first. Now, when we say intussusception, something is entering something, invaginating. So when you look at this one, this is how it is. The normal, should I say, okay, this is the one that is receiving the other. So this one has entered the other one, okay? It's not supposed to be like that. It's supposed to be a continuous dimension as you go along. But when you have a part of the intestine entering, I like using the word entering, another part, then intussusception occurs. When that happens, what is supposed to flow normally cannot flow. A very bad case, there can be complete obstruction when the lumen is occluded. So that is intussusception. And when this happens, we only go and see whether we can, in a very bad case, we'll cut it off. In another case, we'll try to elongate it, but we'll talk about the management as we go along. So that is intussusception, and it can occur in children as well as the elderly. So some of the predisposing factors can be infection or celiac disease, as well as the recent abdominal surgery. And when it occurs, we have the patient having severe abdominal pain, colicky abdominal pain, and then the stool is currant jelly like. So those are the two things. And then because of the impairment in the flow of the gastric content, the person can vomit, and the vomiters will contain something like bile because of the obstruction of flow of the contents from the duodenum down. A person can have bilious vomiting. And the onset is usually sudden because of the acute nature of the phenomenon. Person becomes pale, pulling the legs to the abdomen. And then when you do the physical examination, X-ray and other symptoms, you find that the person may have the condition. It can also be confused with Volvolus, gastroenteritis, and others. So the patients can have barium enema. So the barium enema is given to see whether the place can expand for the one that has gone in to come out. But then if you don't have that facility, you do the laparotomy and try to manually, gently pull out the invagination portion. Or they will just do a resection and anastomosis. So I mentioned the resection and anastomosis earlier, but I'm saying that you can also do a manual reduction, trying to pull the invagination portion out if it's not complicated, if it's not obstructed, if the tissues are not dead, you know, it's patent, but it's just an invagination. So you can have that. Preoperative care, postoperative care, we draw from what that I've been saying already today. Then for volvulus, it's more of twisting. I'm not sure whether I added a picture of volvulus. I'm sure you can find one on the net. So volvulus is twisting. That is a key word here, twisting. The first one entered, invaginated. This one twists, okay? So when you twist, it's like the flow, the lumen is twisted. So the way everything twists, and you know how it twists. The same thing, all the pictures that you see online will show you how it is. And so when it happens like that, there's also an obstruction. And then the patient comes with an acute. It can occur at different parts of the intestine. So When the person comes in, we would also take the person to theater as we have done for the others, and usually it occurs in children. The clinical manifestation that we see are similar to the intussusception, as in the abdominal discharge, the vomiting, constipation, and all those things. So the diagnostic measures are almost the same. So the surgical treatment is what I'm more concerned about, where we have the intestinal bypass around the obstruction. This is not a common approach used. When we say intestinal bypass, the bypass where the twisting has occurred, for one reason or the other, cannot be removed. So instead of cutting it off, they create a bypass from that twisting area. Another one is trying to remove or undo the twist. Or the one I have observed is a resection anastomosis. They just cut the parts that has twisted, because intestine is long, so they cut and then join the healthy parts. That is the most common. Anyway, so this is what we do specifically for Volvolus, and then the pre-op and post-op also relates or rhymes well with what we have discussed before. For every surgery, there are a number of complications, so this one is also no exception. We have complications to do with dehydration, infection, peritonitis, etc.